Atopic dermatitis or eczema is the most common chronic relapsing skin disease seen in infancy and childhood. It affects 10 to 30% of children worldwide and frequently occurs in families with other atopic diseases. Atopic dermatitis affects about 20% of people at some point in their lives. It is more common in younger children, and males and females are equally affected. Infants with AD are predisposed to development of food allergy, allergic rhinitis, and asthma later in childhood, a process called the atopic march. The symptoms for AD typically begins in infancy. Approximately 50% of patients experience symptoms in the first year of life, and an additional 30% are diagnosed between 1 and 5 years of age. Intense pruritus, especially at night, and cutaneous reactivity are the cardinal features of AD. Scratching and excoriation cause increased skin inflammation that contributes to the development of more pronounced eczematous skin lesions. Foods such as cow's milk, egg, peanut, tree nuts, soy, wheat, fish, and shellfish, aeroallergens such as pollen, grass, animal dander, dust mites, and infection such as Staphylococcus aureus, herpes simplex, coccidiovirus, molluscum, and reduced humidity, excessive sweating, and irritants such as wool, acrylic, soaps, toiletries, fragrances, and detergents can trigger pruritus and scratching. Acute AD skin lesions are intensely pruritic with erythematous papules. Subacute dermatitis manifest are erythematous, excoriated, scaling papules. In contrast, chronic AD is characterized by lichenification or thickening of the skin with accentuated surface markings and fibrotic papules. The clinical features of atopic dermatitis, the major features is the pruritus, facial and extensor eczema or redness of the skin, swelling, itching, and skin lesions with sometimes oozing and scarring in infants and children, flexural eczema in adolescents, chronic or relapsing dermatitis, personal or family history of atopic disease. The associated features are cirrhosis, cutaneous infections, or Staphylococcus aureus, group A, Streptococcus, herpes simplex, coccidiovirus, vaccinia, molluscum, warts, or non-specific dermatitis of the hands or feet, ichthyosis, fulmar, hyperlinearity, keratosis pilaris, and niphal eczema. Laboratory is the elevated serum IgE levels, positive results of immediate type allergy skin tests, early age at onset, Denny lines or Denny Morgan intraorbital folds, facial erythema or pallor, course influenced by environmental and or emotional factors. The cause is unknown but believed to involve genetics, immune system, dysfunction, environmental exposures, and difficulties with the permeability of the skin. If one identical twin is affected, there is an 85% chance the other also has the condition. Atopy is an immediate onset allergic reaction, type 1 hypersensitivity reaction that manifests as asthma, food allergies, AD, or hay fever. About 30% of people with atopic dermatitis have mutations in the genes for the production of filaggrin, which increase the risk for early onset of atopic dermatitis and developing asthma. The hygiene hypothesis. According to the hygiene hypothesis, early childhood exposure to certain microorganisms such as gut flora and helminth parasites protects against allergic diseases by contributing to the development of the immune system. This exposure is limited in a modern sanitary environment, and the incorrectly developed immune system is prone to develop allergies to harmless substances. Atopic dermatitis sometimes appears associated with celiac disease and non-celiac gluten sensitivity, and the improvement with a gluten-free diet indicates that gluten is a causative agent in these cases. Atopic dermatitis in children may be linked to the level of calcium carbonate or hardness of household water when used to drink. The differential diagnosis: contact dermatitis, psoriasis, and seborrheic dermatitis. The treatment for AD requires a systematic, multi-phased approach that incorporates skin moisturization, topical anti-inflammatory therapy, identification and elimination of flare factors, and if necessary, systematic therapy. Avoiding woolen clothing is usually good for those with AD. Likewise, silk, silver-coated clothing may help. The role of vitamin D on atopic dermatitis is not clear, but there is some evidence that vitamin D supplementations may improve its symptoms. Topical corticosteroids, such as hydrocortisone, have proven effective in managing AD. Other medications used for AD include systematic immunosuppressant, such as cyclosporine, methotrexate, interferon gamma-1b, mycophenolate mofetil, and azathioprine. Antibiotics, either by mouth or applied topically, is commonly used to target overgrowth of Staphylococcus aureus in the skin of people with atopic dermatitis. However, a 2019 meta-analysis found no clear evidence of benefit.